All right, you guys. So we're jumping into another complex disorder. This time we're going to be talking about sleep disorders. And I really love this image. It makes me laugh because a lot of times when we think about sleep disorders and we think about snoring and we think about issues when it comes to sleeping, we think about, and typically there is a trend that it's more of men that have sleeping problems. But it can happen to women as well. So I really like this image because it brings equality to, sleep disorders. But when we talk about sleep disorders, what we're talking about is it is defined as an abnormal breathing pattern during sleep. So that's the simple version of it when we talk about sleep disorders. There are specific terms that we have to be familiar with. And here's a list of common terms that we have to be familiar with. We're going to talk about some of them. Some of them we've already talked about before in other lessons, and others you are going to have to spend some time getting familiar with on your own. But here's the list. We're going to talk about apnea, obstructive apnea, central apnea, mixed apnea, hypopnea, obstructive hypopnea, central hypopnea, arousals, respiratory effort-related arousals, hypoventilation, Cheyne-Stokes breathing, and the American Academy of Sleep Medicine. All of these are terms that we need to be familiar with and have an understanding of when it comes to sleep disorders. Now, we've talked about Cheyne-Stokes breathing. We've talked about hypoventilation. We've talked about those two already. So when we talk about hypoventilation, what we're talking about is patients whose CO2 is elevating and they're not able to eliminate the CO2 that their body's producing. When we talk about Cheyne-Stokes breathing, this is a breathing pattern that has this crescendo, decrescendo look with a period of apnea. So there's a couple of things that we've already talked about, but you need to be familiar with all of these by the end of this lesson. And like I said, some of them we're going to hit, but we're not going to cover all of them. So when we talk about sleep-related breathing disorders, what we're talking about are a kind of plethora of different disorders. But our four main ones that we're going to talk about, we're going to talk about obstructive sleep apnea, we're going to talk about central sleep apnea, we're going to hit some mixed and some sleep-related hypoventilation and hypoxemia syndromes. Whew, that is a mouthful. Sometimes we get these disorders and it is alphabet soup. We are hearing OSA, CSA, MSA, and SRHHS. So we're sometimes seeing and utilizing this alphabet soup, and we need to make sure that we know them as a full term and what they could be abbreviated with. And we're going to talk about these in depth. The other ones that we're going to look at, the other ones that we're going to not necessarily spend as much time on, is sleep-related breathing disorders. And this is kind of the overarching category that we have for the rest of these. So sleep-related breathing disorders, you can have insomnia, which is patients that are struggling to stay asleep. You can have hypersomnias of central origin, which is another class of sleep-related breathing disorders. We can have circadian rhythm sleep disorders, parasomnias, sleep-related movement disorders, isolated symptoms and normal variants, and miscellaneous. So when we look at these, there's kind of like, if we were to look at categorizing different felines, right? So you have feline, which is the overarching umbrella for sleep-related breathing disorders. And then you have puma, you have tiger, you have lion, you have house cat, you have all of these different types of cats that fall underneath that umbrella. And that's what we're talking about, are just these alternative classifications of sleep-related breathing disorders. So when we look at obstructive sleep apnea, this is a common disorder that's often requires lifelong care. And when we look at this, approximately 25% of adults in the U.S. have obstructive sleep apnea and is a major cause of excessive daytime sleepiness. And when we look at this, the cardinal features that are associated with obstructive sleep apnea are obstructive apneas, you have hypopneas, you have respiratory effort related arousals or RERAs, which are caused by reoccurring collapse of the upper airway. So during periods of obstruction, patients are commonly quiet. They look like they're holding their breath, really. And when this happens, the brain and the diaphragm and the body is trying to increase the effort to have a breath. And oftentimes, these apneic episodes only end after there's an intense struggle. So if you can imagine, while you're trying to sleep, you have this internal struggle that's going on and you don't even know about it. But because that struggle is going on, how well do you think you're actually sleeping? Which leads to the excessive daytime sleepiness. And so we have these sonorous or snoring-like respirations or sounds after those periods of apnea. A lot of times you end up with patients that suddenly wake up or they sit upright and they gasp for air. And we'll talk about why that happens throughout this talk. And so when we look at this, there are a number of reasons why a patient may have obstructive sleep apnea. And you may wonder why we have this old school picture here. It's because Charles Dickens, the famous author from the 1800s, wrote a Prometheus Papers of the Pickwick Club that was actually published in the early 1800s, 1837. And when he did this, what he was doing is he was looking at, and he recognized that this little boy would sit on a bus bench and he would fall asleep. And the character in this movie, or this character in this book, has a description of Joe, the fat boy who snored, had excessive daytime sleepiness, and may include the classic features of what we now describe as sleep apnea syndrome, with hypercapnia, with obesity hypoventilation syndrome, or what we have now is what's called Pickwickian syndrome. So a lot of times when we have patients that have obesity hypoventilation syndrome, so when we look at obstructive sleep apnea, we can have patients that they don't specifically have to be obese in order for them to have obstructive sleep apnea. You can have patients that are not obese or within the normal body limits of their range that still have obstructive sleep apnea. You can have patients with tracheal malacia, or patients that have a large tongue, or what we call macroglossia. Those are different things that can lead to patients having obstructive sleep apnea. Some of the patients that are notoriously known for having macroglossia are those that have trisomy 21 or Down syndrome. Down syndrome patients or Down syndrome people typically have a larger tongue, or that is a common feature when it comes to Down syndrome. So you don't have to necessarily be overweight. You can be a fit, healthy, athletic person and end up with obstructive sleep apnea. It is not isolated to obese patients all by themselves. So some of the signs and symptoms that we might see when it comes to obstructive sleep apnea, we're going to see the loud snoring. What do we do for patients who are snoring? There's a lot of things that we can do to help work on this. You might see them stop breathing or have a cessation of breathing while they're sleeping. You might get those abrupt awakenings that accompany shortness of breath and they're gasping for air. They may have difficulty staying asleep. This is insomnia. You have moodiness or irritability. You may have a lack of concentration. It's funny, every time that I talk about these sleep disorders, I always have students that are like, oh, no, that's me. I have that, like, that's a sign. I have that symptom. I have that. And then they start to think that they have obstructive sleep apnea. No, like, don't always isolate or identify yourself as having a disorder based off of the signs and symptoms. You know that it needs a variety of exams and more information before we can actually get to any diagnosis. But you can have memory impairment. You can have awakening with dry mouth or sore throat. You can have a morning headache, nausea, excessive daytime sleepiness, or hypersomnia. We can have intellectual and personality changes. These patients could be depressed. They can have nocturnal uresis, which is overnight. You have the need to urinate often. You can have sexual impotence and night sweats. So some of these signs and symptoms are those that send a signal to the patients that they need to get this taken care of. One of the things that a lot of times men will respond to is recognizing that their sexual impotence is from their sleep apnea. So they're wanting to get that thing worked out. So they are quick to sometimes get their sleep studies so they can get all systems working, if you know what I'm saying. And then night sweats. Sometimes these patients are going to have night sweats because their body is working all the time. Their brain is working. It is fighting, trying to just breathe. And through that mental struggle, through that patient trying to get and fight for those efforts, it can lead to the body increasing their metabolic demand, leading to those night sweats. So lots of signs and symptoms that can lead to us recognizing that there's a potential for obstructive sleep apnea. Just note that there may be some overlap. We talked about night sweats with tuberculosis not long ago. So just make sure that when we have night sweats that we're putting it in the right category. Do we have other clinical manifestations that are associated with the obesity or the macrosomia or some of the other risk factors when it comes to these patients maybe having OSA versus TB? And when we look at the risk factors for obstructive sleep apnea, we've got excessive weight. More than 50% of our patients are diagnosed with OSA are overweight. So those fat deposits sit around the upper airway and they press on that upper airway, causing that obstruction. Another risk factor is looking at that patient's neck size. So what we will do is we will put a measuring tape that goes around their neck. And if for guys, their circumference of their neck is greater than 17 inches, then they're at an increased risk for OSA. Females, your neck size needs to be 16 inches or greater for having that increased risk of OSA. Patients with hypertension typically have OSA. And then you can continue to see what some of the other ones are with autonomic narrowing of the upper airway when it comes to just pharyngeal tissue or enlargement of the tongue that we talked about, macroglossia. You can have tonsillar hypertrophy, which is abnormally large tonsils or adenoids. You can have a deviated septum, laryngeal stenosis, vocal cord dysfunction, and we'll talk about it in a slide coming up, but the Mallampati score. We'll talk about that. Chronic nasal congestion, diabetes. Guys, we're more likely to get OSA compared to women. Those that are elderly, greater than 65 years, ages under 35 years, it's going to be our Black Americans, it's going to be our Hispanics, Pacific Islanders. All of those of heritage are going to be at an increased risk as well. Women, if you're going through menopause, you're at risk and you've got a family history of sleep apnea, then you're also at risk. And these last two are things that, we can typically control for the sleep apnea. So anybody that's on alcohol, sedatives, or tranquilizers, or they're smoking, they all of those that are exposing themselves to those things are at a higher risk for OSA. And we know that with alcohol, it is a depressant. It's a respiratory depressant. It's like a sedative or a tranquilizer. So when that happens, you get a relaxation of the upper airways that can lead to that not alveolar collapse, but tracheal collapse. So the criteria that we're looking at when it comes to truly diagnosing these patients is we have to differentiate between the patient being symptomatic or asymptomatic. So when we look at those symptoms are, do they have sleepiness? Do they have fatigue, inattention? Do they have disturbed sleep? Are they having a restless sleep? Do they have respiratory pauses? Do they have snoring? Are they waking up, gasping, and are they short of breath? So those are the symptomatic patients that we're going to talk about here in just a second. First, we're going to start with the asymptomatic. So they are not having any of those symptoms or signs of disturbed sleep. So the asymptomatic patients, they have to have 15 or more apneas, hypopneas, or respiratory effort-related arousals in an hour for them to kind of get this diagnosis of obstructive sleep apnea. Well, not only do they have to have 15 or more of those, there's more information or there's more qualifiers. They have to have more than 75 of those apneas and hypopneas. Those have to be obstructive in nature. And we're going to talk about and we're going to differentiate between obstructive and central sleep apnea in here in just a second. So if we have a patient who is symptomatic, they are symptomatic, showing the sleepiness or the fatigue, the inattention. They have snoring, restless sleep, and or respiratory pauses. These patients, they only have to have 5 or more hypopneas, apneas, or RAs per hour for them to kind of get the criteria to open the door for them to get the diagnosis. They still have to have 75% or more of those events need to be obstructive in nature. So we can look at 2 different criteria when it comes to, is my patient symptomatic or are they asymptomatic? If you're asymptomatic, you got to have 15 or more events, and 75% of those have to be obstructive in nature. When we have a symptomatic patient, you have to have 5 or more events, and those need to be more than 75% obstructive to get the full diagnosis of OSA. So the next thing that we need to do is we need to identify, does this patient have mild, moderate, or severe OSA? And this is a screenshot from one of the old books that I used that breaks it down super easy. So what we're looking at is, are there events that are 5 to 15 events per hour of sleep? Or do you have 15 to 30 events per hour of sleep? Or do you have 30 or more events per hour per sleep? And your SpO2 has to drop